My name is Lorraine Joseph Kandathil, and today I'll be presenting a very interesting topic alongside my colleagues Nicola Oliveira, Professor James Patterson, and Professor Georgi Chernav. So the topic I'll be talking is about personalized one-step melanoma surgery, a new horizon for dermatological surgeons. Before I start, I'd like to say that all authors declare no conflict of interest, and this research did not receive any financial support. So here our clinical case is of a 40-year-old female with Fitzpatrick type 2, and here we can see a solitary lesion on the posterolateral aspect of the lower left leg. The patient notices a progressive change in size and shape and therefore seeks a consultation in March of 2021. Comorbidities of the patient was Hashimoto's thyroiditis, but it was controlled with levothyroxine. Otherwise, the patient was healthy. Here we see the solitary lesion on the posterolateral aspect of the left leg, and we also see on the central aspect there is an ulcerative nodule. So the overall clinical picture here is a single pigmented patch identified with measurement of 2.5 centimeters. The lesion was asymmetrical with irregular shape, unclear borders, and uneven coloring. Center of the lesion was exudative and an ulcerative nodule was identified. Clinical and dermatoscopic findings were consistent with the diagnosis of a superficial spreading cutaneous melanoma. So here again we see the picture of the ulcerative nodule in the center alongside uneven borders and color. So with paraclinical data, blood tests were without deviation, ultrasound of the lymph node in the abdomen and the retroperitoneal organs showed no signs of tumor spread. Chest radiography was without any deviation. Laboratory testing showed elevated uric acid levels, and S100 marker and LDH were within normal limits. All other parameters were normal, and here we have the working diagnosis of cutaneous melanoma. So from that, we were prepared with our primary surgery. So following the recommendation of the American Joint Committee of Cancer guidelines, a primary resection of 0.3 to 0.5 centimeters safety margin in all direction was performed. So here we see the resection with safety margin and the patient under general anesthesia. And the closure of the defect was with single interrupted sutures. Once the resection was done, it was sent to histology and showed breast thickness of 4 millimeters, Clark type 4, class B, with high mitotic activity but with no spontaneous regression. There was insignificant lymphocytic stroma reaction and a clear resection margin. Our staging here was 2C. After the post-diagnostic workup, we see chest and radiograph of the abdomen and CT showed no signs of metastatic dissemination, and a week later the patient was sent to the National Oncology Hospital for re-excision and sentinel lymph node biopsy. The second surgical session was then conducted, so therefore a re-excision with an additional 2 centimeters from the previous surgical scar was performed, as well with the parallel removal of the sentinel lymph node. Closure of the defect was after done, but then led to an unfortunate complication of the wound dehiscence and failure to close successfully. About 1 to 2 months after the cleansing, rebandaging, and administration of antibiotics, there was visible improvement and resolution. No other complication has been reported to date, and the patient is with well condition. So here we see after the second re-excision, and then on the right side we see the sentinel lymph node drainage. Slowly we see the dehiscence happening, so we see erythema, we see the inflammation or the inflammatory phases happening here. And again, dehiscence of the wound, but after complete rebandaging, antibiotic re-administration, we see a complete closure of the defect. So in discussion, what exactly is cutaneous melanoma? Well, first of all, cutaneous melanoma is still a major clinical challenge, especially when considering the increasing incidence of small lesions that have been recorded in the last decades in developed countries, as well as that 22 and more notably in the Caucasian population. Melanoma is still the main cause of death due to the skin cancer. As per the guidelines set by EJC and the European consensus, define that intermediate thickness melanomas of 1 to 4 recommended to be surgically removed by 2 surgical settings. The American guidelines suggest treating all intermediate thickness cutaneous melanoma within 1 to 4 with a variable margin of 1 to 2 centimeters, but always with sentinel lymph node biopsy, but of course in 2 surgical sessions. The guidelines here lack specificity for both the clinician as well as the patients. The guideline for clinicians when dealing with such a wide range of tumors may lead to much confusion, as tumor thickness is the key indicator for disease progression or else prognosis. For this first time, we would like to introduce 2 subgroups of medium thick skin melanomas. So intermediate thickness class A, which is known as 1 millimeter to 2 millimeter tumor thickness, and class B from 2 millimeters to 4. The European guidelines state that the total resection field for class A is 1 centimeters, achieved in 2 sessions alongside drainage, and class B is similar, but total resection field should be 2 centimeters, again in 2 surgical sessions alongside parallel removal of drainage lymph nodes. The key issue with the AJCC guidelines here stems on the recommendation of resection surgical field with thickness between 1 and 2 millimeters, meaning it can vary between 1 centimeters and 2 centimeters. So therefore, we can understand that AJCC recommends for a surgical treatment of melanoma thickness more than 1, and those with more than 4 millimeter could be identical. In practice, we can say that thick melanomas and intermediate thickness melanomas, class A or B, is very similar, but this leads to much confusion. For cases with class A or B, we however suggest 2 centimeters with sentinel lymph node biopsy when echographically it is more than 4 millimeters thickness or below 4 millimeters thickness or more than 1 millimeters, as well as in favor of the clinical and dermatoscopy cutaneous melanoma more than 1, as well as for thick melanomas that could be between 2 or less than 2, when we have metastatic spread additionally with or without sentinel lymph node biopsy. So here we see the first table that is recommended by the AJCC. And here if we focus on the tumor thickness more than 1 to 2, here they say a variable resection field of 1 to 2 centimeters, but always in 2 surgical sessions. This is a more elaborate table by AJCC, which again, focusing on 2 millimeters to 4 millimeters, it says that a total surgical session, after 2 sessions, it should be 2 centimeters in all directions with sentinel lymph node biopsy. However, reciprocity between the clinical and histopathology measured in the surgical margin is not required in these guidelines, and therefore we always say it is necessary. Here we look at the modified EJC recommendations, and as well focusing on more than 2 millimeters, the total surgical margin is told to be done in 2 centimeters in all directions. Here as well, just as AJCC, the reciprocity between clinical and histopathology measured surgical margin does not require, or at least it has not been mentioned about, always in 2 surgical sessions. This is our OSMS recommendation. With thickness of 1 to 2 millimeters class A, we recommend a total of 2 centimeters with SLNB, as well as thickness of 2 to 4, which is class B, 2 centimeters with SLNB in all directions, with the requirement for absolute reciprocity between clinical and post-operative surgical margins, always the necessity of only 1 surgical session. So some questions that we could say at this point is, why do these guidelines exist at all? Why do equally treated surgical melanoma show different tendencies to metastasize and different prognosis in general? Answers can only be found in the lack of unification of the criteria of AJCC, maybe. Given such a generalized approach to the treatment of cutaneous melanomas, we are compelled to summarize a few potential flaws that AJCC may address to be in failure of. The variability of guidelines allows for possible confusions, where a borderline thickness cutaneous melanoma of 1 may potentially be treated in the same way as a thickness of 4 millimeters. Or else patients with borderline thickness class A and B melanoma are once again treated equally with no distinguish of the form of a personalized treatment strategy. As well as this, till present day 2022, There is no condition of reciprocity between clinical and histopathology margins. The latest guidelines that was updated in 2021 by EJC recommends that a surgical treatment of melanoma may have a possibility of extending a surgical excision even after the surgical session. And what this study ultimately said was that it actually lacks clarity. The possibility for a third surgical session for the treatment of cutaneous melanoma. Although it is not mandatory, it gives the clinician a choice of performing an additional clear resection when histopathology is possible for the tumor tissue. We suggest with the OSMS the requirement for absolute reciprocity between clinical and post-operative histopathology, always achieved in one surgical session. The European consensus advocates for more precise treatment, however, recommendations for the intermediate thickness melanoma, but with the same two-step approach as AJCC. According to the European guidelines, tumors ranging from 1 to 2 millimeters thickness, considered as Class A, are treated with a total of 1 centimeter surgical session, together with SLNB. Class B tumors with a thickness of 2 to 4 are treated with 2 centimeters surgical safety margin, along with SLNB. Our decision is 2 centimeters and SLNB in 1 surgical session, when clinical and dermatoscopic is indicated for possible cutaneous melanoma, more than 1, and with preoperative echogenic measurement of the lesion in favor of less than 4 and more than 1 millimeters. So the OSMS treatment is a much more personalized approach. It aims to follow a more precise, tailored treatment plan that reaches the intended result of both recommended guidelines, but in 1 surgical session. Our guidelines follow the intended European framework of the corresponding surgical safety margin for tumor thickness, alongside sentinel lymph node biopsy. The OSMS identifies 2 borderline intermediate thickness melanomas A and B, and suggests a more adequate recommendation for their management in 1 surgical session. In case of tumor thickness in Class A or B, the treatment is 2 centimeters and sentinel lymph node biopsy, in total surgical margin of 1 session. So why is OSMS the better option here? First of all, fewer interventions. A surgical session that requires preoperative measurement of the tumor thickness but guarantees surgical treatment with 1 surgical session only. Therefore, a clearer treatment plan is seen here. As well as this, it's a more easier patient traceability, higher cooperation, reduced hospital stay, reduced psycho-emotional stress on the patient, and reduced cost. So therefore, in conclusion, here we have our patient with 4 millimeter breast lobe thickness, could be treated with a defined 2 centimeter surgical session with or without sentinel lymph node biopsy after tumor board discussion, but in only 1 surgical session. Though histopathology verification of the tumor thickness is the gold standard and the primary reason for employing a 2-step approach, using a high-resolution ultrasound or echography to determine a preoperative thickness is being increasingly used and has shown to correlate well with the histopathology of breast lobe thickness. Even this has not been conducted in this case, however, we do recommend this in the future cases. OSMS requirement for absolute reciprocity between clinical and histopathology maybe reduces the reoccurrences. OSMS minimizes the possibility of error or failure to meet the deadline for a second excision in combination with a lymph node biopsy. Thank you for your attention.